I actually moved that down a little bit, so I'll pull. I think so. Testing? Yep. We're not, I don't know if any of us
say
on
we're
here.
friends.
I don't know if anybody here
Yeah,
is
we know each
above
other
6
pretty
foot,
well,
so.
We could have split them up, but we didn't want to, get two fractions there. Okay. All right. Is this on? Can everybody hear me? Not so much? How's that? Is that better? Okay. Welcome, everyone, to End-of-Life Care in a Changing Healthcare Environment, the impact of the Affordable Care Act and accountable care organizations. And welcome to Northwestern. And the biggest welcome present, I do have a parking validator for those of you that pulled a ticket. So I've got it here, and we can stamp it anytime. I'm Mary Mulcahy. I'm a medical oncologist here. I'm a board member of the Chicago End-of-Life Care Coalition, and one of the sponsors, which is one of the sponsors of tonight's event. I'm a co-founder of Life Matters Media. We're an organization dedicated to enhancing the dialogue surrounding end-of-life decision-making, and we're doing it through the media and mainstream. Our vision, much of which is shared by the CECC, is that everyone can be informed about the choices and decisions they face. They can take an active role in deciding their course. Patients and providers understand the importance of advanced care planning and early discussions. Medical providers, we hope, will become better equipped to initiate and propagate a conversation about the end of life, and that the healthy, the ill, families, caregivers, and healthcare workers can turn to us as a leader in journalism, education, communication, content, and navigating this time. LifeMattersMedia.org has been running since June, but we saw a clear opportunity with the conversation and controversy surrounding the Affordable Care Act to engage with our audience live. Along with the CECC, we realized that there currently exists a real dearth of information and media attention upon this facet of our changing healthcare system. We needed to close that information gap and navigate the complexities and multifaceted nature of end-of-life care. The Chicago End-of-Life Care Coalition was organized in January of 2000 in response to a national call for local education efforts to improve care for the dying, sparked by the PBS documentary series On Our Own Terms, Bill Moyers on Dying in America. The CEC's work continues to evolve and respond 13 years later, and tonight's event is an example of that evolution. The CECC is an all-volunteer, non-for-profit, founded by Advocate's very own Julie Goldstein, an internist, clinical ethicist, and palliative care physician at Illinois Masonic. Julie currently devotes much of her time to the development and improvement of the IDPH Uniform DNR Advanced Directive Form, known as POLST. CCC is currently led by Karen Long, the Director of Development at Horizon Hospice and Palliative Care, and has been in the field of end-of-life care since 1995, when she was part of the communications team that helped announce the results of the Robert Wood Johnson Foundation support study. She then worked with the Foundation's Last Acts Communications Project. We'd like to do more such live events in the coming months. When you entered, you received a questionnaire. If you fill it out all or in part, it would be quite helpful to both of our organizations in providing services targeting identifiable needs. One other thing to mention is that both Life Matters Media and the CECC are very happy to invite all of you to a reception afterwards. We have wine, beer, and dessert so that the conversation can continue, and that will go on right outside in the lobby there. The first part of this event will be a structured panel discussion. It will be followed by time for audience questions. When that time comes, if you have an inquiry, raise your hand. We'll get you a microphone. And please keep your questions short, focused, and respectful. We recognize that this is often a heated subject, and we aim to handle it tonight in a most professional way with our esteemed speakers. Here to introduce them and to guide our discussion is CECC board member and Life Matters Media co-founder Randy Bellosomo. Randy's also a reporter at WGN-TV, a contributor to Chicago Public Radio, and a graduate of the University of Notre Dame and Northwestern University's Medill School of Journalism. She's currently pursuing graduate work in bioethics and health policy at Loyola University in Chicago, while she serves as a volunteer with Horizon Hospice. As an extension of our work online at Life Matters Media, Randy and I are currently engaging in a citywide tour this fall to start the conversation about advanced care planning at each of Chicago's 22 senior centers. We look forward to sharing what we've learned from seniors, what they've learned from us, and other results in the coming months on what should be a comprehensive demographic analysis of where advanced care planning stands in the city's landscape. Please welcome the woman who put this panel together, Randy Bellasoma.
Thank you, Karen. Okay. Thanks for being here. The Patient Protection and Affordable Care Act may be one of the most significant and seismic pieces of health law in the history of the United States. And in most of our lifetimes, it is perhaps the most controversial social legislation. However, according to a survey this fall by Kaiser Family Foundation, 51% of Americans say they still do not have enough information about the law to understand how it will impact their families. 2/3 of those who are uninsured report the same. What are its goals? Greater access for the 37 million Americans with no health insurance, reduction of health care costs by a shift away from the current fee-for-service system, and increased consumer benefits and protections. Millions of more doctor visits will now occur, with as many as 30 million additional people obtaining health insurance coverage in the coming years. How will those numbers impact the care that you receive or the care that you provide? Are ACOs simply a repackaging of HMOs, and are doctors at risk financially? And are there enough of the doctors? The Association of American Medical Colleges reported the U.S. is short about 20,000 physicians, and that shortage is going to quintuple in the next decade due to the aging of our population and the wave of retirement that accompanies the life phase into which many baby boomers are now entering. The Affordable Care Act is impacting medical education too, which is something we will be touching on tonight. What are we entitled to? Do we deserve it? How does this new approach fit into our already hybrid system of health care? And where do we fit in culturally and socially in the global landscape? These are questions we will try to answer. Tough ones, especially through a fuzzy prism of end-of-life care. Come the questions about what is essential at the end of life. Is there rationing? What is rationing? And what about Sarah Palin's death panel? I can assure you that the only death panel working tonight is the one right here, and they aren't the deciders of any of your health care. They're just here to inform you about the changing landscape you may soon be embarking upon when it comes to making choices for you or your family, or for others in your personal or professional care. Bruce Japsen has written about health care for more than 20 years, starting in his native Iowa, where he covered the presidential campaign bus rides of Bill and Hillary Clinton through the Hawkeye State, talking about health reform and the economy. He's covered the rise and the fall and the rise again of health reform, not only chronicling national trends, but the influence of Barack Obama from his current home state here in Chicago, Illinois. Bruce is now a healthcare columnist at Forbes magazine, on our own platform at Life Matters Media, and a contributor to the New York Times and Chicago Medicine magazine. He teaches writing at Loyola University Chicago and health communication at the University of Iowa. Bruce thinks that Americans should be talking about healthcare like they talk about football, and tonight's event, we hope, is a small step towards achieving a culture shift of greater health literacy and education. Dr. Lee Sachs serves as the Executive Vice President and Chief Medical Officer of Advocate Healthcare, the largest health system in Illinois and one of the largest providers in the Midwest, currently operating more than 250 sites of care. He's the CEO of Advocate Physician Partners, a network that includes more than 1,100 primary care doctors and 2,500 specialists. He's a graduate of the University of Pennsylvania and of the medical school at UIC. Dr. Sachs has been the president of the Illinois Academy of Family Physicians and has served on the Commission of Healthcare Services of the American Academy of Family Physicians. He's been chairman of the Institute of Clinical Quality and Value. He's a true pioneer in the approach that has come to be known as accountable care, offering financial incentives for doctors and hospitals to cut costs. Dr. Joshua Hauser is an assistant professor in medicine at Northwestern University's Feinberg School and on the faculty of the Buehler Center on Aging, Health, and Society. At the Jesse Brown VA Medical Center, Dr. Hauser serves as the chief of the palliative care section. He also directs an ongoing education project, the Education and Palliative and End-of-Life Care Program, or EPIC. Dr. Kayhan Parsi is the director of the graduate program in bioethics at the Neiswanger Institute for Bioethics at Loyola University Chicago, where he's been on the faculty since 2002. He has served on the board of directors of the American Society for Bioethics and Humanities, the professional organization for bioethicists in the United States. He served as a book review editor for the American Journal of Bioethics and as the journal's associate editor. Prior to joining Loyola, he worked at the Institute for Ethics at the AMA. His education is all Texan, with a bachelor's degree from Rice, a law degree from the University of Houston Law Center, and a PhD in medical humanities from the University of Texas Medical Branch of Galveston. I'm going to start by talking with each one of the panelists, and they're going to speak individually for several minutes, and then after we get through each panelist, we can open it up for questions. But I'm going to start with a man right next to me with Bruce, and by asking you to give us a brief overview of where we are today, how we got there, and we want to focus on end-of-life issues, particularly later, but I want to set this up with someone who's watched health reform consistently over time. What is the temperature of our climate right now?
Well, I hope not to disappoint you, and I'm not going to be like some of the pundits on TV, although sometimes I am a pundit on TV, and talk about the website and all the problems with that, which obviously are serious. But I'm going to talk to you about how in the Affordable Care Act and how things have evolved in this country is that no matter whether there was health care reform or not, employers, and most people here probably have employer insurance, or maybe you're on Medicare or Medicaid, or maybe VA insurance, there's no more money. People are either unwilling or unable to pay more for care. And so that is what has changed. Now, I've been writing about healthcare in Chicago for 20 years, and the way that the former management of Northwestern Memorial was able to pay for this, and it's now a 15-year-old hospital, is through fee-for-service medicine. You know, the more people you care for, the more money you make, and so forth. That party is going away, and so, and I'm sure Dr. Sachs will talk a little bit about more of the accountable care effort, but what's changing is the fact that healthcare is moving in the direction of maybe the restaurant industry or the auto industry. You go to a restaurant, you get a bad meal, you either don't pay for it or you get a coupon for a free meal the next time. You drive a brand new car off a lot, there's a lemon law that protects you. You don't get stuck with that, or they say, oh, sorry, we're going to bill you, you have to buy another new car. The car you just paid for is broken. You'd get a new car. Now, in healthcare, that is only now just changing, where part of it is because of the Affordable Care Act. Part of it is because companies and employers are just not going to pay for everything like they used to. And so there are certain things like hospital readmissions. If you are going for a surgery in a hospital and you get an infection while you're there and it's the hospital's fault, within 30 days, essentially, Medicare is not going to pay for that mistake, nor should they. All sorts of things like that are going on in healthcare, and you're sort of thinking to myself, well, why wasn't it like that? It probably should have always been like that. But I think it's happening because people, in Illinois in particular, we ain't got no more money. So.
In a column, Bruce, that you published on our platform and that has been circulated to others, you argued that the Affordable Care Act actually improves end-of-life care overall. Why did you write that?
Well, back to my comment about how there are a lot of things in this healthcare law. The biggest thing now are the glitches on the website. That's because people in my profession, they don't know or haven't read all the legislation. They don't know healthcare. It's complicated. It's easy to write about glitches on a website. So haven't said that. But in the bill, back to the whole quality idea, with hospice care, there are hospice providers that effective October 1st of this year, for the first time, they have to report data to the federal government, to Medicare. Hospice gets reimbursed from Medicare. Medicare pays for hospice care. And so they have to report various quality measures to the government. And if they don't, they get a 2% cut in their reimbursement. Now, the providers do not like that. They don't like a lot of things. Being from Iowa, I can tell you after a drink about how a lot of them are kind of like farmers. They just want to get paid for doing what they do without being held to certain accountable standards. And so the good thing there is, over the course of time, Medicare will, there will be more measures. Now, you might say, what do you measure? Someone is at the end of your life. One of the measures is, was the pain of the patient brought to a comfort level within 48 hours? Now, there's no financial repercussion, like they don't say, okay, Northwestern's hospice got the pain under control in 47 hours, which is good, and then another facility got it under control in 50 hours. There's no financial penalty yet, but other than the fact that you've just got to report this data, but they're going to be able to report all this data into the federal government and then be able to compare. And then maybe one day, soon, hopefully, you might be able to go to a website if you have a loved one who is sick and at the end of their life, and be able to go and say, you know what, on this measure and that measure, that provider didn't do so well. So maybe I'm going to put mom or dad, my brother or sister, in this other hospice. So that is part of the Affordable Care Act. Okay.
I'm going to ask you another question, but it needs some setup. Back in 1990, the Patient Self-Determination Act required that healthcare institutions provide information about advanced health care directives to adult patients, with no mention of any discussion about the actual directives themselves. 2 decades later, early versions of healthcare reform called for paying physicians to discuss advanced care planning with Medicare patients. But that idea was shot down many times for many reasons, the most notable after the criticism that the reimbursement equaled an attempt to save money by expediting the death of the elderly through federally sanctioned death panels. The provision came up again after the passage of the Affordable Care Act. Despite the medical community's support, opponents argued that doctors would be enabled to throw Granny off a cliff, and the proposal was once again dropped. Can you bring us up to date as to where this idea stands now, reimbursement for doctor-patient end-of-life dialogue, and do you ever think it will be a reality?
Well, I think, and what she's talking about there is that, how much, what was was it $45 or something in that Palin got all upset about? What was it? What was the fee to the doctor? That was $45 or something. Anyway, it's a small amount of money. Essentially, the death panel thing. Sarah Palin brought up this idea, and it was essentially to give the doctor reimbursement to have a conversation about how someone should advance directive. So that was shot down because of the whole death panel, her and John Boehner and a whole bunch of other people. So now that is, it's probably not going to happen like that, but it is happening. So within certain structures called accountable care organizations, which Dr. Sachs can speak to this better than I can, I know of some where if you're, they're given maybe a lump sum of money, or if they have to care for a population of people, and they decide, last year we paid you $5 million to care for this population of people. And if you meet all these quality measurements and lower the costs to $4 million, then you, the group of providers, get to keep half of the million you saved. My understanding is that within the framework of the accountable care organization, the providers can do kind of, not what they want, but they have a lot of latitude. They can incorporate hospice into their care plan. So I guess the short answer is there's more coordinated care going on now, and it's going to have to be like that because, as I said, nobody has money to just pay fees for service for everybody. So what's going on with the development of electronic medical records, accountable care organizations, and better care coordination is that the hospice provider is more likely to actually have a conversation with the oncologist and the primary care physician and all sorts of other people. More likely. I'm not saying that it's all happening, but it's more likely, and the payments will be set up that way.
Thank
That's
you.
what's going on.
Thank you. I'm sure you'll have questions afterwards. I'm going to move on for now to Dr. Sachs. As background, Dr. Sachs testified before the Senate Finance Committee regarding Advocate's clinical integration program, which was started in 2004 with 36 measures aimed at primary care doctors. It's a pay-for-performance program. Advocate Physician Partners has since been identified as a model organization by the Federal Trade Commission. By fostering collaboration among payers and patients, physicians, and hospitals, the framework has evolved into an ACO with one of the nation's largest shared savings PPO contracts between Advocate and Blue Cross. You say, Dr. Sachs, that it all comes down to value over volume. Please talk about that concept, your success at Advocate, and what it means for end-of-life care as a whole.
Thanks, Randy. It's a pleasure to be here and hopefully to contribute to this important topic. First of all, as Bruce outlined, the economics of healthcare are mandating the need for reform because it threatens the economic viability of our country. If I had brought one slide, use your imagination, a graph that shows the per capita healthcare spend in the U.S. compared to 6 Western developed countries by 10-year age groups, and the trend in the lines are almost identical until you get to 55. And between 55 and 65, the U.S. starts to go up, and after 65, we go off the chart with that. And if that doesn't change, it threatens our future viability. Now, the irony is that the Affordable Care Act is mostly focused on the below 65s and reforming the commercial, individual, and Medicaid insurance market, but it will spill over to Medicare and those over 65. It's my contention that it's not that our, family members and fellow citizens are sicker or less healthy at 60 and 65. It's that our Medicare benefit does not cause beneficiaries to have any, for lack of a better term, skin in the game. Over 90% of Medicare beneficiaries have first dollar coverage, either between Medicare and their supplement or because they're on Medicaid and Medicare. So if something's free, you'll consume as much of it as you want, whether you need it or not. I see that in my own family. It's fascinating to see the things that my wife will do when it's quote free with that. I see it with my mother who was a nurse and is clearly a reasonably well educated regarding health care, but she lives in South Florida, which has the highest health care costs for Medicare in the country. And after the second week of January, she's met her out of pocket for the rest of the year. And after that, I mean, one time she called me and she had had her 3rd nuclear stress test within 2 years. And this is a lady who doesn't have any heart disease, but they gave her donuts and a cup of coffee. So we have to fix that. And, one of the problems is Bruce talked about fee-for-service, and, if you get paid on piecework, your goal is to do as much of the piecework as possible. And hospitals have been paid on piecework, and doctors have been paid on piecework. And you come out of medical school, and you're naive and idealistic, and you want to do the right thing, and pretty soon you come to grips with, unless you're in a unique situation, you have to make a living, which means seeing more people and not having the time for the difficult conversations when we get into end-of-life care. So the Affordable Care Act, a lot of it is related to insurance reform. What we're dealing with right now with the exchange and the sign-up is offering coverage to people who didn't have coverage or people who allegedly didn't have good coverage, the individual insurance market, which discriminated. If you had a serious illness or a chronic condition, you were quickly priced out of the market. So going forward, there's only 4 criteria to base your premium on. It's your age, your sex, your geography, and whether or not you smoke. It used to be that they could look and see if you had diabetes, did you have asthma, were you diagnosed with cancer, and everybody knows the horror stories that if the answer to some of those questions was yes, the premium was unaffordable. So we had a lot of people who were uninsured, or they were locked into a job that had insurance and couldn't take a risk on trying a different job with an employer who wasn't a large employer with insurance. So the good news is it may take a few years, but the projections are 30 million people will have more coverage, and there's going to be a Medicaid expansion. Today in Metro Chicago, 25% of the people are covered by Medicaid. And the expectation is with the Medicaid expansion, there'll be another 500,000 people who have access to coverage. That's a good thing, because right now these people wait for crises. They end up in the emergency room. It's episodic care. They certainly never have an opportunity for a conversation about long-term planning or with chronic disease and things like that. So our organization is responsible for over 500,000 lives in a so-called ACO, or Accountable Care Organization. We're accountable for the outcomes of care, the service, and the cost, the so-called triple aim. And this grew out of Medicare demonstration projects, and the Affordable Care Act created opportunities to further this with Medicare. So we have roughly 120,000 Medicare beneficiaries who are our attributed patients, where we're responsible for doing this, so that all of a sudden it's not the more is better, let's see how many things we can do and how many bills we can generate. It's how do we keep Mrs. Jones with diabetes under control so that she can get another 10 or 15 years of high quality life, and along the way avoid the known complications of diabetes which drive healthcare costs, whether it's kidney failure, heart disease, blindness, et cetera. And hopefully it's taking a long-term perspective. You know, as a family physician, one of the things I saw was that patients were loyal to my practice many times over a lifetime and over multiple generations. During that time, they switched insurance companies, they switched jobs, they lost insurance coverage, their employer switched insurance carriers. So it's not a wonder that whether it's Blue Cross, United, Humana, et cetera, they're looking at a one-year snapshot and how do they minimize their expenses for that year, and they're not investing for 5 and 10 years out, because the likelihood is half of the people they're covering are going to belong to their competitor with that. So, you know, all the reasons why the economics in the past haven't been helpful. So when you have an alignment, and theoretically if we outperform the Medicare marketplace, we're entitled to capture some of the savings. It gives you a lot of freedom to invest in things that traditionally don't get paid well, one of which is a lot of face time and conversation with that. Historically, when physicians do procedures, when they do surgery, when they do cardiac catheterization, the reimbursement per amount of time is much higher than when you sit and talk to a patient with that. So, I mean, other examples would be to deal with some of the social issues that undermine good health care. If the patient doesn't have transportation and can't get to my office and keep an appointment, it doesn't matter how good I am, they're going to miss an opportunity, or if they can't afford to get their prescription filled. So we're willing to invest in things like that to help enhance the outcome. You know, a story that gets told in all kinds of medical meetings when you talk about alignment. In Southern California, when they had a heat wave, a progressive physician group said, you know, we've got X number of asthmatic patients who will not do well in this heat wave and drought. But if they had air conditioning, we probably can avoid having them in the emergency room or in the hospital. And they went out and bought room air conditioners and installed them in people who didn't have the means to do that. Now, that's certainly not traditional thinking for a physician. And in the days when I was in a 3-person practice, that clearly wasn't something that we would have thought of, let alone been willing to do. But when you're responsible for, you know, hundreds of thousands of patients, that's a reasonable investment with a return. So the last thing I'll comment on, I alluded to, you don't get paid proportionally for your time. And most physicians don't have adequate training in conversations about end-of-life issues. It's awkward, it's uncomfortable, they didn't teach it to me in medical school, and I suspect they're not teaching it very well now. So one of the eye-openers to me is our organization is thinking about how do we best manage these 530,000 patients, engage them to make informed decisions, because as we learn repeatedly, if you have a thorough conversation and are open and honest with patients, many times they'll choose options that the physicians wouldn't necessarily have thought as what they wanted. You know, most people want to spend the end of their life at home with family and friends. They don't want to be hooked up to machines in an intensive care unit. They want to be assured that they're going to be comfortable and die with respect and dignity with that, and not wait until it's 12 hours, you know, from the end, you know, when they're comatose, to have somebody tell their family, I think it's time to call the rest of the family. So we've been training our care managers, and we modeled this after a program of all places, La Crosse, Wisconsin, which is a progressive community that's really made this a community initiative. And for our frontline care managers, it's 6 one-hour online self-learning modules, and it's an 8-hour training class, and then it's role-playing to get comfortable. And then we're training a cohort of 40 advanced practice nurses by disease specialty. So the nurses who care for the congestive heart failure patients know the ins and outs of heart failure and what are the stages and, you know, what do you anticipate as you near the end. The oncology nurses, you know, specialize in oncology. So these nurses are doing another 6 one-hour modules and 2 8-hour training sessions with role-playing and follow-up coaching as they start to have conversations that typically take several hours in multiple settings before a patient and family are comfortable with asking the questions that are deep down inside and making their wishes known. There are only a handful of physicians that are able to do that, let alone willing and have the time with it. And that's, you know, an outgrowth of our, you know, perverse system with fee-for-service. So I'm cautiously optimistic that with the changes that organizations like Advocate and others being more responsive to our patients are going to invest the resources to do things like that. And inevitably, patients and family will realize that these are things that are going on, and they're going to come and ask, and they're going to drive further change. But it's hard for me to remember a patient ever coming into my practice and saying, could we have a conversation about advanced care plans or end-of-life issues with that. But I won't be surprised in the next 5 to 10 years that's going to be much more commonplace with that. So maybe I ought to stop here.
That was a positive note to wrap that on. We'll get back with more questions after that. For the time being, I'll move on to Josh. During the past year, Northwestern has been involved in the adaptation and teaching of the education and palliative and end-of-life care curriculum. EPIC. EPIC teaches core skills in like symptom management, communication, ethics. It's an adaptable program that can be modified from hospital to hospital. How, Josh, has the changing environment that the Affordable Care Act is fueling changing education?
Great. Thank you, Randy, and thank you, Mary. I do want to answer that. I want to make a few overall comments to start with. I want to thank Mary and Randy for including a high school picture of mine on the flyer. Each year that I get older, I appreciate that more and more. So thank you, guys. I think I want to take a little bit of a step back and use this as a chance to reflect a little bit on the Affordable Care Act and medical education overall, and I hope as I do that, kind of zoom in on palliative care education, which is, as Randy said, kind of my passion. And it's also nice to see a number of friends in this audience. And the main point I want to make is that in regards to medical education and the Affordable Care Act, there's a paucity of knowledge and a lot of uncertainty. As my homework for this night, I did a literature search, as all good doctors do, on Medline, and I found more than 2,000 citations for the Affordable Care Act, and more than 130 citations for medical education, and 39 that combine the two of those. So there's actually not a lot known or written about this, and as with a lot of topics that generate more heat than light, when you do a Google search, there are many more citations than there are in Medline. But let me tell you about some of the titles that came up. Here's one: The Best of Times, the Worst of Times, Academic Medicine in Turbulent Times, I'm Sorry, but I Must Object. That's from a journal called Missouri Medicine. Enough Already, and Physician Burnout, a Potential Threat to Successful Healthcare Reform. That's 6 out of the 39 citations that I found, and I think it represents, again, people's anxiety and uncertainty. And when I say people, I don't just mean patients and families, I actually mean people like doctor people and provider people. There was a survey of medical school deans about whether they felt students were prepared to understand the Affordable Care Act. 58% said no way, we have not enough teaching about healthcare policy. And they actually also surveyed medical students and the Affordable Care Act. And believe it or not, medical student support for the Affordable Care Act is right around where public support is. It's around 50%, 45%, those kinds of numbers. And it actually varies by political affiliation, as you might imagine, with Democrat being greater than Republican. It varies by amount of debt, with higher debt being less supportive than lower debt. And it varies by intended specialty. Primary care physicians or people intending to go in primary care support it more than people intending to go into specialties. Only 48% of students, and this is kind of disappointing, 48% of students endorse the statement, I understand the basic components of the Affordable Care Act. And 41% were undecided in whether they actually supported it or not. So 45% do support it, 41% didn't even know enough to support it. The title of this article was Medical Students in the Affordable Care Act, Uninformed and Undecided. Now, despite all this, there are a few concrete issues I want to touch on, and then I want to come back to your question, Randy. So the first is there's going to be increased funding for primary care in the Affordable Care Act. There'll be increased amounts of payments for physicians in primary care and slightly lower payments for subspecialists. And there will also be sort of better provisions for loan repayment for students and for residents. So as a specialty, and I'm going to use that word in quotation, as a specialty of medicine that I think of as really an intensive form of primary care, I think palliative care is very well positioned and I think has the tools to sort of help this rise of primary care. And this will push us, and Dr. Sachs talked about sort of how to push doctors, this will push us to better integrate palliative care with primary care. So that's my first sort of educational point, that the increased amount of primary care will help sort of push development in that area. The second is the issue of patient-centered medical homes, which are related to accountable care organizations, as Dr. Sachs just talked about. The emphasis on issues of transitions of care, coordination of care, teamwork is going to push us as medical schools to develop more curricular material in these areas. And really, as kind of one of the bread and butter issues of hospice and palliative care, teamwork and interdisciplinary care, and attention to transitions of care, that will sort of position us very well to contribute to that part of education. The last point I want to make of the 3 points is this issue of the potential for burnout. Remember, that was the title of the last article. I said physician burnout, a potential threat to successful healthcare reform. So this was a really nice piece. Again, it was more of a perspective piece than it was based on data, but it brought up several important points. When you look at writings about the Affordable Care Act, you see all these wonderful things that doctors will be able to do. They'll be on teams, they'll be team leaders, they'll be innovators, they'll be paid for quality, they will be accountable for more things, et cetera. And those things are very sort of stimulating and exciting for all of us. But with those multiple roles comes the potential for overwhelmingness and burnout. So that's another thing that we need to pay attention to. Again, palliative care as a specialty actually has lower rates of burnout. This has been studied by some of these same authors, has lower rates of burnout than many other medical specialties, and it's because sort of one of our, I think, fundamental hopes is that we pay attention to our own care as we care for patients and their families. So to the extent that the Affordable Care Act might expose us as physicians, and I'm speaking as a physician, to more burnout and more overwhelmingness, I think some of the, again, teachings and practice of palliative care can help nourish that. So those are the kind of three education points I wanted to make: increasing primary care doctors and the opportunity for palliative care to integrate better with that, patient-centered medical homes and teamwork and how palliative care can be part of that, and then this issue of burnout.
I've got another question.
Yeah, but I didn't answer your first question,
Oh.
which was about sort of medical education. And you know, the
Obfuscated that. You're
Yeah, I
very
apologize.
yes.
I guess I'm on point or off point.
You're right.
The program that Randy refers to is an ongoing continuing medical education program that I've had the privilege of being a part of for a number of years now, called EPIC, Education in Palliative and End-of-Life Care. And it's a program that we've actually had more success at the practicing physician and practicing clinician level than we have at the medical school level. And that's not said with shame or pride, but just as a finding. We've also been working, and Jessica Montalva's in the audience, and Jessica's a colleague of mine, with another program where we're working with community hospitals on intensive training around goals of care conversations. And this involves some of the things that Dr. Sachs was talking about, role play and standardized patients and simulation. And it also involves a year-long mentoring of these hospitals in how they implement these goals of care conversations. So that's another example of at the sort of practicing physician level. You know, at the undergraduate medical education level, as I said, there's a lot of emphasis both at Northwestern and many other medical schools in more communication training and early exposure to clinical aspects of palliative care and other medical specialties. So I think that's where we'll keep working. But medical education is a diverse practice. In the 140, 126, 112, whatever the current number is of medical schools, there are exactly that number of communication classes and that number of, actually slightly less than that number of palliative care programs. So it's a fairly diverse portfolio, for better or worse. But all of these things have the potential for us to become more involved.
One more.
Yes.
But I got to set it up. Beginning in January, all new health insurance plans will be required to include coverage for essential health benefits. Each plan must, at the very least, cover 60% of the medical costs on average of enrollees. My question is, what is the definition of essential care? It's often debated at the end of life. Is it essential? Is it beneficial? Is it futile? These are questions asked by physicians, families, ethicists. Dr. Hauser is a palliative care physician, and what are your thoughts on what appears to be a rather ambiguous definition of essential care at the end of life?
That's an easy one, Randy. Thank you. So I don't have a clear answer for that. I think that the things that patients and families over and over tell us they want and they need their symptoms and their comfort managed. That's essential. They need their choices elicited about where they want care. And sometimes that's home. And interestingly enough, it's more often home when we're sitting in a room like this than it is when we're really sick. So when patients get sicker and sicker and more dependent, fewer and fewer still want to be at home, because home can be a tough place to be, it turns out. Despite that, we still don't do a good job with getting patients home. So elicitation of that choice is essential, and trying to meet that choice. I don't know if we can always meet that, but it's essential to at least broach that topic. The last thing that I think is essential is some manifestation and concretization of this issue of non-abandonment. And this is an important topic in medical ethics, and it's an important topic that we talk about. What it means is that no matter what happens, we are going to be with you. And the you is the patient and the family, and the we is some version of us as doctors, nurses, chaplains, social workers, and other people involved in care. And it's an interesting topic as to who does that. And I was just with a group of lay people earlier today doing another conversation, and someone said to me, well, the doctors never do that. That's always the nurses. That's always the other people. Are you crazy to think the doctors do that? And I do think doctors, for all sorts of reasons, have shied away from some of those topics. But this issue of non-abandonment and how we follow and stay with people is essential.
Thank you. I can quote the Affordable Care Act in saying that the government must ensure that the health benefits established as essential not be subject to denial to individuals against their wishes on the basis of the individual's age, expected length of life, or the individual's present or predicted disability, degree of medical dependency, or quality of life. This is a topic of much concern as this was all debated. I think it was important to point out. I'm going to move on, and then I'm sure Dr. Hauser will have some questions for him too, and I'm going to move on to Kahan. You teach a course entitled Justice in Healthcare, and in it, your students examine different health systems and reflect on our own. With the passage of the Affordable Care Act, where do we fit in culturally and socially on the global scale?
So that's a good question, and there's a lot of empirical work. There's a lot of comparisons between this country and other developed countries. We typically don't fare very well when we're compared head-to-head on health outcomes. To the point of your question, I think what's interesting about it, and this is something that actually I discussed recently with a former colleague of mine, Steve Latham, and we were talking about this system, and you mentioned earlier, Randy, us having this kind of hybrid system. And we live in a very pluralistic, fragmented healthcare environment compared to other countries. Other countries long ago made up their minds as to what kind of system they want to commit to that reflects their values, their culture, their priorities, their ethics. And we haven't made up our mind. We've been struggling with this issue for well over 100 years. You know, when I tell my students that this didn't start with Clinton, it didn't start with Nixon, it didn't start with LBJ, it didn't start with Truman, it didn't start with FDR, it started with the other Roosevelt, with Teddy Roosevelt, 100 years ago. That was the first proposal for any kind of universal health care program in this country. So it dates back over 100 years. We've been trying to figure out what kind of nation are we? Are we a nation committed to universal health care for everyone, regardless of your income, your race, your ethnicity, who you are? Or are we a country that's comfortable with having primarily a free market-based healthcare economy, and then the government kind of fills in the gaps? So what we've seen over the last 100 years is attempts at universal healthcare coverage failed under FDR, failed under Truman. Finally, under LBJ, we get significant legislation, Medicare and Medicaid. The fact that it got passed is nothing short of remarkable, but it reflects just that kind of unique historical event in our history. You had the death of a young, charismatic president who had this vision for health care. You had Democratic majorities in both houses of Congress. And you had pending civil rights legislation. So all of it, you had this perfect storm in '65 of the government saying, okay, we're going to cover seniors. We're going to cover people with disabilities. We're going to cover people that are indigent, women and children. So Medicare and Medicaid was born. And we were, you know, despite the animosity towards it by my former employer, the AMA, actually physicians became great beneficiaries of Medicare. Medicaid perhaps less so. But so for the last 45, 50 years we've been struggling with, okay, we've done this, but what kind of nation are we? Are we comfortable living in a country with 45, 50 million people underinsured, uninsured? And so we've struggled with this. Clinton didn't get anywhere. And finally, with the election of Obama, again, we have this kind of perfect storm, Democratic president with this kind of progressive agenda, 2 Democratic majorities in both houses. And so then we finally have this, you know, legislation passed in 2010. With regards to international comparisons, I want to go back to what my colleague Steve Latham said. He said, if you look at, you can have a national health plan or program or service like the UK. Well, we have that with the VA. You can have a national health insurance plan like they have in Canada. Well, we have that in Medicare. You can have a social safety net. Well, we have that with Medicaid. You can have an employer-based program, which is what Germany and Japan do. This kind of, it goes back to Bismarck in the late 19th century. It's kind of corporatist model. Well, that's what we have. I mean, 50% of us enjoy pretty good health insurance through our employer. But it's this kind of weird hodgepodge, hybrid, blend, whatever you want to call it, and yet it has significant gaps. And now, even with Obamacare, the Affordable Care Act, we still have significant numbers of people that are uninsured, underinsured. So I think that when we look at international comparisons, I mean, they help inform us. Oftentimes when I discuss this with my students, sometimes someone will say, well, I mean, isn't the U.S. exceptional? We're different from these other countries. I mean, you know, you can't compare us to Switzerland or to France. I mean, the U.S. has 300 million people. We have significant, you know, underrepresented communities and underserved communities. So is it really fair? And I'm thinking, well, do you really want the U.S. to be 37th or 38th or whatever it is in the OECD comparison? You know, we should be doing better. So I think that's hopefully the benefit of looking at these international comparisons is to better inform how we can do a better job at meeting the needs of our citizenry.
When providing health care often comes down to is determining the best allocation of resources. That's often the crux of bioethics. So I was wondering if you could talk about the concept of resource allocation, how that may differ from rationing, that we hear many of those who have been opposed to the Affordable Care Act have been discussing. What is the role, is there a role, of resource allocation / or rationing in Obamacare?
Well, we already ration. I mean, we do invisible rationing, or kind of a non-transparent rationing. I mean, people that don't have insurance get rationed. You can show up at the emergency room and get screened and stabilized. But beyond that, there's not really a lot of resources available. So there's already kind of implicit or invisible or soft rationing. And with Obamacare, I think it goes back to what we heard earlier with regards to the incentive structure. So historically, the incentive structure is you do a lot of things and you get paid to do those things. And the new incentive structure is we're going to have these affordable or accountable care organizations. We're going to have populations. The goal is to incentivize people to prevent illness, to manage their chronic illness such as diabetes, to not wait, to not reward people for doing things or doing procedures. And that's a kind of rationing. So when we talk about resource allocation, when we talk about a lot of different theories of justice, and we talk about libertarian approaches or utilitarian approaches or liberal theory approaches, I mean, again, it goes back to what I said earlier, is that we really haven't made up our mind in this country. And so we just kind of we have a kind of laissez-faire approach to a lot of these issues, and then we try to, again, shore up the gap with these interventions, but still leaving significant communities unserved or underserved.
As a bioethicist, you're familiar, obviously, with the guiding principles that underlie not only the conduct of biomedical research, but the thinking of those in your field across all the issues: autonomy, beneficence, justice, non-maleficence. In your opinion, does the Affordable Care Act embrace these guiding principles to an acceptable degree?
Well, obviously, I mean, the principle of justice is the one that comes to mind. That's been, I mean, it's interesting because Beecham and Childress wrote this book over 30 years ago, and the focus historically on those 4 principles was always on autonomy. I mean, that was what garnered a lot of attention. That's what a lot of the major cases were about. Quinlan in the 70s and the Cruzan case. A lot of the end-of-life care cases revolved around autonomy, about the ability for individuals to make their own healthcare decisions at the end of life. Justice was always kind of the, I don't know, the bald-headed stepchild. And so that was never really, it was never at the forefront of the literature up until maybe the 90s. And then the last 12 to 15 years has been this just burgeoning of literature that looks at justice issues, global justice. Beecham and Childress now talk about global justice in their books. And I would think they would think, since they're the ones that with the progenitors of these four principles, they would think the Affordable Care Act is at least an attempt to address these issues of social justice, of distributive justice. In fact, they say in their chapter on justice that the issue of justice dwarfs all the other issues in this book. So despite the fact that autonomy's garnered most of the attention, they recognize the centrality of the issue of justice, that we all want to live in a just world. We all want to live in a more just healthcare environment. So I would think that they would think that at least the Affordable Care Act is a modest attempt, maybe not a complete attempt, maybe not a truly transformative attempt, but at least a modest attempt.
Thank you. Those are my questions for now, and what we're going to do is raise your hand if you have a question, and we'll bring you a microphone, and you can ask any of the panelists what you want to ask, and I'm going to take a step back.
Hi, sorry. I'm a graduate of the Loyola Master's Program in Bioethics. The Justice in Healthcare course was fantastic.
I didn't pay you to say that, Jody. So.
No, I paid you.
Touche.
Big time.
I'm also a staff chaplain at Advocate Good Shepherd Hospital, and so that's my connection to Dr. Sachs. And I'm chair of the ethics committee with a physician co-chair to help me, with communication and things like that. Here's my question, and this has kind of been where I've been living the last few months. When we talk about autonomy and we talk about advanced directives, what we're generally thinking is you have the right to refuse care. We don't, and that's something that we embrace, but we're not so big on autonomy when the patient turns around and says to us, I want everything done. I want to be resuscitated. The family member who says, I knew my mother, she would want to continue. She wouldn't want to, be a DNR. She would want to be a full code. And so we get all apoplectic, and we call ethics consults. Sometimes we call psych consults. Anything to move people. We barrage people with, don't you understand and don't you see? And I've had a number of family members in the last couple of months who've turned to the doctor and the nurses and said, you could say this as many times as you like. I'm telling you, this is my value. My value is life at all costs. I don't care what it looks like. So my question is, how is the Affordable Care Act going to address that? I mean, I realize that people don't have a positive right to demand futile treatment. On the other hand, continuation of treatment, resuscitation efforts, people can keep going for a good long time, if people are refusing to withhold or withdraw. So that's my question. Everyone.
Clearly everybody has the right to different values, and we have to respect it. And some people will say that, I want everything heroic, experimental, et cetera. And I guess one of the benefits of the Affordable Care Act is that over time everybody should have coverage so that, the finances aren't an issue. But I think, and I'm sure you'd agree with me, that having that conversation when somebody's in the hospital in critical condition with their family member, many family members make judgments that may not be what their loved one would have done in a lucid moment, 6 and 12 months earlier. We've all seen situations where there's estranged families and there's guilt, or there's concern that if I do this, what are the siblings, going to do, and all those dynamics. So I think going back to what I said earlier, having these types of conversations in a relaxed, comfortable environment outside of a time of stress, anticipating where things are going, allows the patient or the future patient to make that decision. I also want to jump in on we've heard a lot of questions about the R word, rationing, and it's certainly sensational, and it got into the campaign with death panels. But for every anecdote about the hazards of rationing, there's probably 5 times as many evidence-based studies that say that too much care can be harmful. And in the current or the system before the Affordable Care Act, where more is better, we could all cite a number of things that were done that really didn't have strong evidence, and probably many of you in the room have had a diagnostic test that was equivocal that led you and your physician to say, well, I need to do another test. And each level that you go on becomes more complicated, and some of them lead to serious complications with that. Now, when the incentives are to do more, we tend to overlook, but more isn't necessarily better with that. Theoretically, the Affordable Care Act is going to lead to much more transparency about quality. If the healthcare.gov ever works the way it was designed, you're going to be able to look at what's the network, how much does it cost, and what's the quality. Although everybody that I've talked to, including people in Massachusetts who have 5 years of experience, say that almost everybody stops at the price. And the assumption is that the quality's there. Think about when you go online and buy an airline ticket. I'm guessing that 98% of us look for the lowest priced one and maybe would trade off the schedule and convenience a little bit. Or when you go to buy gas, you look at the price on the corner, and if it's cheaper across the street, most of us will drive across the street for that. That's a concern that price is going to drive a lot of decisions, and in the short run may lead to some surprises and unintended consequences. Ultimately, you know, you have to have faith that the public is going to discriminate enough, and if there's a insurance product or a delivery system that's substandard, transparency will get the word out and people will migrate away from it. But when you're buying benefits for a year at a time, you could get locked into a substandard product.
I can echo that too, as just someone who's written about this. I mean, with the within the Affordable Care Act, certainly the hospice providers are going to have to start reporting more data, and eventually, I think they'll be held accountable through lower payments if they're not reporting certain data, and eventually measures and so forth. But regardless, in the employer community and the insurance companies, I mean, we talk about this being this liberal Affordable Care Act. I mean, we have to remember that the insurance industry, which is, I don't really think is historically been accused of being a bunch of left-wing bomb throwers, this is their bill, and they're charged with dealing with the employers and how to pay for care, and they are pushing for the transparency and the ratings. And in the Bush administration, this started with, you know, rating health plans, rating care, being more transparent, reporting who the good doctors are and the bad doctors and whatever through. Now, granted, they may analyze it based on claims data, and doctors don't do that, but outside of this market, there's in Cleveland and other places where all the doctors and hospitals are on board with submitting their data to a common place and posting it online. And I think that's all coming. It may be slow, but it's coming.
Just one couple quick comments. I love your image of sort of us getting apoplectic when patients want more interventional care, and I happen to agree with it. Agree with the image, not necessarily the practice of us getting apoplectic. I think that a lot of this is a challenge for us around kind of communication and how we frame these conversations with patients, as a couple people have alluded to. And I think we've often abdicated our role as physicians around advising and counseling and recommending for patients. We sort of say, what do you want? And we say, do you want this? Do you want that? And those things, I think, are respectful of patients, and that's important. But patients after patients after patients and families say they actually want more advice and counsel from us. Again, not with the goal of convincing them to do this or this, but with the goal of giving them more, kind of regarding what Bruce just said, more data. So talking with them about how we think this interventional care might help or might not help. In the end of the day, there will be people who make decisions different than what Dr. Goldstein wants or what Dr. Hauser wants or what whomever wants. And we need to come to some peace with that. As I said, I think we need to advise and counsel, but at the end of the day, in our current system, patients have rights, and those are important rights, and we may well be disappointed with how patients decide things, but that's okay to be disappointed. And we need to kind of, again, advise without bullying. I think that that's kind of what you were alluding to, is sort of hitting patients over the head with, you must do this. How can you think of doing this? So thank you for the question.
I just wanted to add something to what you were saying, Jody. I think this is really one of the biggest challenges of doing clinical ethics consultations, because oftentimes you're faced with a situation where it's not necessarily clear the benefits and the burdens. And the benefits and the burdens may be interpreted differently from the patient's family versus the healthcare team. And so is that enough? Is education, counseling, data, is that enough to persuade people to choose one choice as opposed to another? Or does it really take a kind of very significant cultural shift in attitudes about that we live in a world of finite resources, and if we all do this at the end of life, when it's clear that there is no benefit, or at least physiological benefit, I think that's going to take a lot more work. It takes a lot more dialogue. I mean, you know, so it's, and I don't know if that's going to happen because of the Affordable Care Act.
Go ahead.
Hi, I also work at one of the Advocate hospitals, so at Good Samaritan Hospital, and I've been in healthcare long enough to have seen the trend from, you know, when we really didn't worry about transitions of care and end-of-life care or anything, to now really focused on outcomes and a lot more autonomy for the patient. But one thing that I see, at least at Good Sam, and I think it's in the Midwest in general, that really bothers me and I think is a huge threat to this movement and also to continuity of care and transitions, is the growth of hospitalists. And to be honest, that really, really concerns me. And I wondered if Dr. Sachs could talk to that, because what I see happening is patients come in the hospital and their primary cares are left in the office. There's no communication. The hospitalist can handle the care of the patient while they're in the hospital, but then they're sent back to the office. And many of these issues come up while they're in the hospital, not dealing with a physician they have a long-standing relationship with. Someone who comes in the room and says, you know, this is feudal care where, you know, we want to put you on palliative care, and the patient and family are saying, who are you? I don't know you. You know, and how do we, that really bothers me, that this is a trend that I've seen even in the last 5 years that has just burgeoned, at least at the hospital I'm at.
Yeah, there's certainly good and bad about hospitalists, but I think it's a symptom of the specialization in medical care. So I'm a generalist in family medicine, and when I trained, and you can figure out the era, you know, we were trained to deliver babies, we were trained to assist in surgery and to care for lots of things. Pretty quickly in an urban metropolitan area where there's an abundance of specialists, it didn't make sense to go into the operating room. It didn't make sense to deliver babies. And I can remember having conversations with patients who needed surgery, and someone would look me in the eye and say, are you going to be there? And I learned to answer that I'm not going to be in the operating room because Dr. So-and-so is much more skilled, and we've, you know, arranged for him or her, but we're going to be in communication, and, you know, I'm going to be available to coordinate your care. We need to do the same thing with the hospitalists. You know, my old practice in the recent years, as it grew, and I think today it's 8 physicians, decided that it was more efficient to have one of them round on every patient for a week at a time. So quasi-hospitalists, you could have been seeing Dr. Smith and suddenly you're in the hospital and it's Dr. Jones who's taking care of you. Within that group, we always figured out how to communicate and hand off and step in each other's shoes, and if need be, pick up the phone and call my partner on vacation and say, you know, this is an awkward situation, but what does that family, you know, really want? So one of the things that we've come to say across Advocate, and I have no illusions, we're not close to being there, that we have to do a much better job of transitions of care and handovers. And transitions can be when you get admitted to the hospital. It can mean when you go from ICU to med-surg, but it can mean when you leave the hospital to go home or a SNF or rehab. And every transition has to have a structured data set, and then it has to have verbal, if not face-to-face communication between the caregivers. And unfortunately, in the hustle and bustle, especially in the, you know, more is better and time is a premium, that doesn't always happen. So I see examples of some places where that is done meticulously and every time, and there's lots of others which you're seeing where patients feel like they got shuffled off, and or the nurse who's caring for them in the hospital realizes that the doctor there really doesn't know the 30-year history and the ins and outs of that patient. I actually think that with better alignment of incentives and being accountable, the delivery system will force itself to make those adjustments, because when you don't do it well, you get complications, you get readmissions, you get dissatisfied patients, and those are things that are all getting measured and shared publicly, which ultimately, forces you to look at, your organization and say, we're not the best, and we need to fix it with that. So, that's my soapbox about hospitalists.
She was first.
Hi, thank you. I'm Rick Ferraro, and by the way, I'm crashing this party. I was just walking by from another conference, and a lot of my clients are hospitals, but I saw the title, and I'm a Kellogg grad, by the way, so I'm kind of halfway okay here. But I saw the title of your meeting here, and it struck me because I relatively recently went through this with both of my parents, and fortunately they had made a decision of do not resuscitate, but at the same time you are ultimately as the caregiver given a you're put in the position of ultimately a difficult decision of when is enough, okay? Do not wait. We're not going to do not wait till do not resuscitate, okay? We're going to say, hey, at some point there is no hope. They're in a lot of pain. We're starting to. These were proud, elegant people that were now having to strap down in the bed. So where are we going with all this? So relatively recently, I've had to make that decision a couple of times. So I'm completely supportive of what you guys are doing, and thank you for handling or initiating or putting forth all of these discussions and waving the flag, because I think we as a society have to coalesce about where we're going to do this. And there are people who are going to say, I want everything done, and I don't care what it takes, but who is going to pay for it? And we as a society have to find some middle ground. And I know you're all grappling with that, so I'm speaking to the choir. Just a quick observation here that I went through also recently that you guys may use, and I'm thinking way out of the box. I know you're, in fact, Bruce, I've met you a long time ago, Dr. Sachs as well, but educating on this end-of-life care discussion. And just an observation that I made recently was we had to put a dog down. And this dog had been diagnosed some months earlier with cancer, but the vet assured us, and through our own observation, we didn't think he was uncomfortable. But as it continued, and I don't want to get gross, but there was like a kind of a growth, and we said, hey, before he becomes uncomfortable, and this is terrible, we made the decision to put him down. And I'm not endorsing euthanasia, but I'm just an observation about how we as a society treat pets. We then went to the vet, and we had the family around, and the vet was just brilliant with this, and it was just a very dignified experience, very comfortable for us and for the pet. They gave the pet initially a shot to go to sleep, while my wife held him in his arms and in her arms, and it was just an overall wonderful experience. So I don't know if in your media discussions that's a kind of a, somehow you can work that observation in there. But it struck me is how well we treat our pets versus how much we're sort of pre-programmed to make people less comfortable at the end of their life. So just an observation. Thank you.
Well, if I can address just a little bit too about the media. I mean, having worked at the once world greatest news organization in town, and when I left there and I was doing some stuff at the New York Times, and I'm fortunate enough to get a column with Forbes, and these ladies approached me about doing some stuff for them for Life Matters Media. Through all of this sort of shakeout in the media, there are niches that are coming up. You know, that's the only way media, quite frankly, is going to survive, because newspapers can't be all things to all people, because people don't read in print. And I also teach a college class at Loyola, and I don't. Not Loyola, they're not reading anything, younger people. I don't know what the hell they're reading.
Except for Jody.
unless I make them read. But the good news is there are things that are springing up, niches. I'm not talking about, you know, somebody has a blog or whatever and putting on Facebook, you know, their personal things. But there are efforts like this that are getting backing, some in the private sector, some in the nonprofit sector. And then stories are being told. Now, in my 20 years as a healthcare journalist in Chicago, I never wrote about end-of-life care. You know, very few people did at the Tribune or any mainstream. You know, Terry Schiavo thing comes up and so forth. But I would hate, and I don't want to give Sarah Palin credit for anything, really, but when she did bring this up, and Dr. Donald Berwick, who was the head of the Medicare program, Centers for Medicare and Medicaid, when this went on, and you know, he's out on the circuit. I do a lot of panels. I speak in addition to some different stuff like that. And then when you found out, when you scratch beneath the surface, all the people who are talking about the glitches, you know, blah, 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 Obama's poll ratings are going down, and this and that, whatever, they do not go beyond the surface. But there are some people who do when that came up, and they're like, what is it about this death panel? What the hell is this? And then we found out it was like $45 to a doctor to have a conversation, you know, and that I don't want to give her any credit or anything really, but it did spur some discussion, and some people wrote about it, and I'm writing about it, and they're writing about it. So it's a good thing to you know, elevate this, and it's also in the Affordable Care Act, and people will find it in there after they're fixed the website. So anyway, it's a long answer to say, you know, we're getting there.
Can I just make one quick comment? So I think that the pet analogy is a provocative one, and it's one that I appreciate and others have thought about as well. I think there are a couple pros to it, and there are a couple cons to it. The pros that you identified is, number one, sort of attention to suffering, and number two, kind of presence of family and kind of being together in this decision that you guys exercised. The challenge to the analogy, of course, is that pets don't have any autonomy, so they're not involved in this decision. And the second issue is that they really don't have much of a history, in the same way that a 60-year-old or a 70-year-old or an 80-year-old has 60 or 70 years that preceded his or her visit with me, and that had all sorts of meaning, and that hopefully, if I'm doing a decent job or my team is doing a decent job, that's part of the decision. But I think that the analogy, again, is a compelling one, because it does bring up sort of how focused we are on suffering and on kind of at least a way of making that decision. But I'd push the analogy a little bit around some of those other issues as well.
Hi, I've been a geriatric care manager for almost 9 years, and I've had the conversations with my clients. I've been the one that has sometimes introduced the conversation for clients and patients. When this lady was talking about Good Sam and hospitalists, in the perfect world, and I've been trained with through Respecting Choices for Pulse, and in the perfect world, that whole scenario could change if Pulse was implemented as it has been at the Gunderson Clinic, that people have this discussion long before the crisis emerges, so that the paperwork that is pulsed, that identifies specific wishes, and possibly a companion document to that, 5 choices, and there's other similar documents out there, needs to be brought to the attention of the patient at the beginning. Someone my age, 39. We need to start thinking about these things so that when the person is admitted to the emergency room, and I've been there when people have been misdiagnosed as having dementia. No, that's her sarcastic personality. She doesn't have dementia. Oh. And is this person a full code? No, they're not a full code. This is what their wishes are. If we could get this program implemented correctly so that before the crisis happens, before the family is sitting with the chaplain saying, we think this is what my mother would have wanted, but we're not sure because we never talked about it. I think it's up to the healthcare professionals, be it a physician, a nurse, social worker, or God forbid, a geriatric care manager, to have these discussions so that when the person is brought in a crisis, they have this sheet of paper or these documents that are legally binding saying, this is what I wanted, and this is how I want my life to play out, so that there is no discrepancy between physicians saying, well, we think this. I mean, that's a perfect world, and I really hope we can get that here in Chicago and in Illinois.
I think we all would agree with that. Bruce was whispering to me, don't you guys give people forms? Well, it's not as simple as giving a form, because most of the time if I put the form in front of you, you're going to procrastinate, you're not going to understand it. It's a serious conversation, but having it up front, we're starting to measure what percentage of our patients are, completing advanced care plans. We're starting with specialties where there clearly are end-of-life issues, but I suspect we'll get to all of our physicians and start to create both the awareness and the accountability that's part of serving a population. This is turning the ocean liner. It's a huge change. It does take a lot of training, and it'll be a whole lot easier if the community embraces it. It's more in the mainstream and in the media. You referenced Gunderson and La Crosse, Wisconsin. My understanding is that community where there's really two provider systems have totally engaged in doing that, and we all could learn from it.
I was just going to add to what Bruce mentioned earlier about taking something that's kind of bad, the whole death panels fiasco, and making it hopefully something better. And I was reminded of the whole Shivo case where that was disastrous on many levels. But the good thing was I was thinking at the time, this is 8 years ago, I was hopeful that there would be more conversations about end-of-life care planning. There was the whole Bill Moyers special. I mean, there were these opportunities, and yet it was just like this little kind of nudge, and then people quickly forgot about it. And so it's just interesting to me that people, there has to be this almost kind of revolution in the way we think about end-of-life care, and almost to normalize it. This is what we teach our medical students. We teach them to normalize things that are typically stigmatized, like sexual health history and things like that, drug use, and so. But end-of-life care, we haven't normalized it. It's out of the way. It's done typically in hospitals, and I think if it's not normalized, people don't want to talk about it. People spend more time planning their vacation than talking about. It's not enjoyable, and yet it's like you said. You don't want to wait until that 11th hour.
We're trying to normalize it, Kayan. That's why we're here. So I'm glad. Karen.
I had a question on education. We touched on someone maybe mentioned it, maybe I'm just adding this myself, that there has been the concern that with all these new people now being covered by insurance, will we have enough doctors, primary care physicians in particular, to meet that demand if this program does work? And by extension, should we all be a little bit panicked about the fact, we were talking about this earlier, that there are only 6 palliative care fellowships in Chicago, one of the major medical teaching centers in the country? And I wondered if you all could comment on that. Should we all be very nervous, or a little nervous, or a lot?
Only slightly nervous. There will not be enough palliative care physicians. That's been projected for a long time. which is why the issue of what people sometimes call primary palliative care, in other words, basic palliative care skills around basic symptom control, around these conversations. And again, the conversations in La Crosse, Wisconsin, the conversations here in Chicago need to be happening not with palliative care physicians, not with people like me or Julie, but with Dr. Primary Care and Dr. Oncologist and Dr. Cardiologist, et cetera. And so that's why a lot of the education efforts that all of us are involved in actually aren't for palliative care physicians, they're for everybody else. So I hope that'll address it a little bit. The issue of palliative care fellowships, that will sort of wax and wane. I hope it will continue to wax. But again, that's going to be always a boutique industry and an important industry, and one that fits my passions, and I think a number of the passions of people in this room. But always, for all of us, what's more important, quite frankly, is what I'm doing with the residents who are rotating with me and the medical students who are rotating with us and the hospitalists whom we interact with. Because, again, no matter what, that's where the majority of care is going to be happening.
I'll just say real quick, and then we can take another question about graduate medical education. So across the country, there are record numbers of people who still want to be doctors, despite what you hear. There are more medical schools opening across the country. There are probably like 10 to 20 opening across the country, more medical schools training. However, graduate or residencies fellowship, if we wanted to have 25 or 500 more palliative care physician residencies are funded by Medicare, and they have capped the Balanced Budget Act of 1997, Bill Clinton, they and Newt Gingrich, they capped the number of residencies. There will be no more residencies. We can churn out more and more medical school graduates, but we are not going to train any more physicians than the available slots out there now, because they've capped it, and it's a potential problem, because our Congress could not put together a two-car funeral.
Okay, we're going to try and fit a couple more questions in. Try and keep your questions succinct. And we'll see how many more we can get. And then we have some snacks and beer and wine out front there to continue the conversation. So we'll try for a few more.
Our family has a 30-year history at one of Dr. Sax's hospitals. And as far as the gentleman asked before about euthanizing a patient as they would a dog, well, let me simply state to you that that option was given to me in terms of my father 17 years ago by a cardiologist, and I'm not going to name names or the hospital because I don't know if I'm crossing a line here, but by a cardiologist who recognized that my father was an end-stage CHF and developed a condition that would have meant a more horrible death than CHF. I had the medical power of attorney. The cardiologist came and talked to my mother and I, and we made the decision to go ahead and push the syringe. And the doctor walked us through the steps, told us what would happen, told us what the time frame would be, and that was my father's end. Now, the other thing is, I have a rather colorful medical history myself, all at the same hospital. 4 weeks ago, put my 95-year-old mother into a nursing home, and I've had one physician speak to me about advance directives, and the first time I saw any of the forms were upon the admission to the nursing home, right in the middle of a packet of forms that was about as thick as you would find in a closing packet for a house. So the question is this: why wouldn't you just consider offering these kinds of consultations every year when a patient goes to see their physician, regardless of how old they are, as part of the normal checkup procedure?
Sounds pretty simple. The reality is, in the current system, nobody pays for that. So it doesn't get done except by exception. It's changing, and it's going to change. And just to be crass, if the physician said, "Gee, we're going to spend 2 hours to go through this packet of papers and help you make a decision and maybe give you a video to watch, and it's $250. You know how few people would say, yes, thank you, let's do it. That's the that's the dilemma, and hopefully it is changing with better alignment of incentives and allocating the resources, as well as patients coming and saying, I'd like to have this conversation.
Back to the education issue on a very practical note. First question was about, we desperately need more physicians. You're saying there are more hospitals opening or more medical schools opening. I'm hoping that's not about lowering the standards. We don't want lower standards for the docs. But related to the education, you said, well, the medical curriculum's already very squeezed, and there's stories out there of shortening it further to get students into clinical practice. So how are we going to squeeze all of this communication skill and conversation and palliative care into the medical curriculum?
Well, I mean, medical education is changing in real time. You know, the memorization and book knowledge that was required, you know, when I started, is pretty much worthless because everybody can access that information online instantly with it. So you can, you know, build time into the curriculum for different things with that. You know, underneath the caps on residency slots for the last at least decade, lots of primary care slots went unfilled or were filled with international grads, many of whom went back to the homeland. What happened last year, and some of you may know that there's literally a computer match between medical school graduates and residency slots. For the first time in anybody's memory, and maybe in history, about 700 U.S. medical school grads did not match with the residency because they wanted a match in procedural-based specialties, which have been in demand. And in spite of counseling from medical school deans that maybe you should not think about being an orthopedic surgeon, there'd be a great career in primary care. I suspect when the match results come out this March, we're going to see a huge uptick in U.S. grads matching in primary care, because who wants to finish 8 years of undergraduate and graduate education and have a couple $100,000 of debt and find out that you can't move on and you can't earn a living with that. So the marketplace is starting to change that. I think we're also recognizing that when you align incentives, you know, probably a third of the visits that I had as a family physician could be done online. But in Chicago, nobody pays for that, so we don't do it. In Seattle, in a health maintenance organization, 35% of the primary care visits are online. Patients are a lot happier, it's convenient, it's more cost effective, and a primary care physician can care for a much bigger panel. And that's without getting into teamwork and you know, non-physician providers. So there's lots of ways to be able to provide very high quality and accessible care for the newly insured.
Last question.
Okay, well, this has been a fascinating discussion. My background is long-term care policy for people with long-term, lifelong disabilities and people with age-related chronic health problems. And as I'm sitting here and listening, I'm wondering how you define the time frame then for end-of-life care, because I'm thinking of it from the family caregiver's perspective. They're dealing with someone who has, say, a chronic health problem. Their health condition is deteriorating. At what point do you say you're reaching the end of your life? Is there a medical way of delineating this?
No. No. Let me expand for a moment, but I realize the hour is late. And I think, again, this is a challenge that we all face, and it connects with the conversation about hospitalists before, that we often see, and myself included, because I see patients mostly in the hospital, we see patients at sort of acute point in their illness. And there was, and you know this better than I do, there was 60 years that preceded this and 2 years that preceded that, et cetera, et cetera. So since I say no and I can't define it, what I then go back to is that at every point in time when you're with your primary care physician, when you're first diagnosed with a serious illness, when you're starting a chemotherapy that Dr. Mulcahy is going to give you, when you're starting another chemotherapy that Dr. Mulcahy is going to give you, when you're thinking about adding another drug to your regimen for CHF, all those are points at which these kinds of conversations about goals and advanced care planning can happen. So I think they must and should happen very close to the end of life, when someone might be in an ICU, for example, or really sick in a hospital like Northwestern Memorial Hospital. But that's only kind of the last point. It's kind of the month before that, and the 2 years before that, and the 5 years before that. And as Dr. Sachs said before, that these conversations take a while. They happen a lot of times. But guess what? Everybody in this room actually has gone to the doctor a lot of times. So there are actually a lot of opportunities for this to come up. It doesn't have to come up every time. And that's part of not hitting people over the head with it. But if it does come up once a year, once every 2 years, once every 3 years, then that's a good thing. And we will be doing well if we can at least do that much. So thank you.
Thank you. I want to thank everybody for coming and taking part in what is so under-discussed but so vital. It really means a lot to Mary and to me and to the entire board of the Chicago End of Life Care Coalition. We have had requests in the past couple of weeks from people who are on our mailing list from across the country who wanted a videotape of tonight's event because this is so under-discussed. And I want to thank you for turning out and showing support and making Chicago what we hope to be is an epicenter of the beginning of that culture shift that we've been talking about and normalization of end-of-life issues and discussions. So thank you. Please fill out your survey. It would be so helpful to all of us in figuring out what to do and how to make that culture shift happen quicker. And you can give it to Mary, to me, to anybody on the board. Join us for wine, for beer, dessert, and the folks that had more questions, stick around. They might stick around for a few minutes and answer those questions. I hope they do, and I think that they will. And if you give them a very warm round of applause, thank you. That's it.
Okay. If you didn't get an evaluation form, I have some here. We would really appreciate any feedback you can give us.
Let's go have fun.